to the great extent. I really extend the whole committee the warm wishes for the upcoming years as well as the success of this uh, practical diabetology to the further extent. It is my always pleasure to greet my teachers, mentors, all of you around and making this level to talk to us about health ecosystem. Even this talk has a journey. This is about 10 months back when Dhruvi and I was traveling in a cab to Himalayas, valley and hills, and she asked how the Swasthya journey started, and it is almost 40 years. And yes, we believed in patient centricity first and building on systems and team where we can apply the standards to the most extent. And yes, there is always a question, how can we evolve further way ahead? So in that line, health ecosystem, I'll add from the past to the present and to how we are moving forward to the future. And this whole talk, I want to ignite some questions in all of our, I'll say, practicing to the patient's care, as well as the teamwork, as well as how we build the ecosystem further ahead. So in that background, I'll say the content is why we should evolve the health ecosystem in diabetes. How can we and what could be the pillars of those? Who could be the contributing team members, all the stakeholders, which ways we can build on to, and when that could be possible, and where this system could be existing in the platforms. So when we talk about diabetes, so yes, it's not only the sugar, we treat the individuals, and individuals has these all comorbidities as well as their extensions along with the diabetes. And yes, we are evaluating obesity to the great extent, and these circles goes almost to 60 to 80% of our patients. Hopefully you might have a few numbers or more who have diabetes and obesity together, or maybe a few numbers less, looking into your practice areas and all around. But what comorbidities we see is always we look for their complications and comorbidities to great extent. So when we talk why diabetes, yes, obviously the numbers are rising. IDF atlas of previous and at present, even the predictions of numbers are rising. So let's see how those are evolving. And when we talk about India, so yes, we have a great future ahead. We are there, and we hopefully when we increase in number, the more patients numbers are also increasing. So obviously I wish these young individuals to look forward for their careers in upcoming time. So the numbers are prospective and we can build way ahead. But how we can reduce this trajectory is much more important, and how we reduce the trajectory of their complications is much more important. So yes, it is lifestyle, metabolic, as well as a few extent genetics. Yes, the numbers are rising. Chronic disease, lifelong conditions, there is remission, reversal talked about, but we know how this obesity reoccur or diabetes reappear. So that's where India is world capital. We are part of this health ecosystem, and lack of systemic, coordinated, standardized work in this field is where we can build on to. We have some, I'll say, advocates in the audience, we have some influencers in the audience, we have some, I'll say, stakeholders in the audience, and there is in-depth work could be built into. So diabetes or metabolic disease or health ecosystem, where we can build on is a teamwork. So it's not only the consultant job, it's not only the administrative job, it's not only the hospital's job, it's not only the clinic's job, it's not only the researchers or students' job. It could be from physiotherapists to infection specialists to pulmonologists to the diabetologists to all are part of it. And how we evolve in this team, even the nursings to the paramedics to the phlebotomists to all, maybe our receptionist also could be part of it. So the vision is how equal high quality healthcare for all friends with diabetes or metabolic disease could be possible. And when I talk equal high quality healthcare, it's not only the private sector, even the government sectors or academic institutes or the research institute, how that equal high quality healthcare could be workable options in upcoming time. And where we see it's not only health we are focusing as a merely absence of disease, but what we are focusing, is it just physical health? Is it a mental health? Is it just patient-doctor relationships? Or is it a social health? Or is it a proactive health? Or is it a spiritual health? All are part of this health pillar. And we know what could be, it's all stakeholders, governors could be part of. Now coming to diabetes. When we talk about diabetes, we know what are the comorbidities, what are the complications. It's not only the sugar control, but also how we monitor those individuals and ask them to progress in a further health ahead, further in the time ahead is much more important. When we add obesity, so it's not only mechanical, metabolic or mental complications. There could be even the systemic other complications and gateways along with the obesity. And all we are talking about the upcoming future of India world, where we have lifestyle one of the contributing factor, from overweight to even the cancerous stage, from snoring to obstructive sleep apnea, from a scar to non-healed diabetic foot or gangrene. That's where we are looking into, and that's not the initiation. We see how those gangrenes are looked into the further line. If we see about the initial primary care of foot care, also involved the major aspect. So the mission is harmonize care for effective healthcare service delivery to get optimized outcome in friends with diabesity, and that is throughout the worldwide. So now we have plenty of platforms, plenty of softwares, plenty of web applications, plenty of mobile applications, even the systems of SMS era where we had worked for the patient centricity. Now it has much more become proactive and responsive rather than reactive and regenerative. So it's a way ahead to build on, and even the AI adds the flavor on it. There is patterns, there are data mining, and all can improve the quality of life. So best resource to connect all is information communication technologies. That's the background, I would say the blood in the background of world health ecosystem where we talk about diversity. Even to ensure better compliance to treatment guideline protocols, even the protocols are followed. That's also in the question to look into. So break silos of data collect and amazing data leading to the better understanding as well as positive impact of quality care. Why I insist on data keeping in your way? We started initially with paper data. We built on to the softwares. We generated first electronic prescription in eras of 1990. And from there, we build up to, as present, proactive systems, where systems are working, team members are trained to work in the systems, and then generate the controls over it. And that's where we can build on to. So all stakeholders, like mentioned, it could be from pharmacy stores to investigators, to radiologists, to the pathologists, to the phlebotomists, to the super consultants. All could be part of these stakeholders for holistic lifelong care of these individuals. So yes, there are further scope of innovations. When we talk about innovations, so it is not only to the prevention side or diagnosis side, all era, treatment, education, research, and even outreach of individuals. Then in perspective of how we entered those patients into the environment. So how the patients are seen, how they are heard, how the patient's needs are fulfilled. That's where we look into the health ecosystem to much more extent. But yes, the quality of innovations, how the cost is benefited to individuals, how the safety is taken care, and those efficacies are matched in outcomes, that is possible. So we start with the CGMS, how it was before 2001 and how it has evolved. We have the Asia's first CGMS that was of pager size, only for 3 days retrospective data. And then at present we have 14 days, Bluetooth pad, real-time data that is not only paired with the patients, that is paired with our AI systems with APK shared. So there are responsive, reactive systems all around. Same insulin pump, it has evolved. So these are the technologies on insulin pump, even the investigational technologies. Not only previously, maybe sir would be knowing about how you would be testing the urine and detecting the diabetes. So Benedict test was the diagnostic perspective for in 1970s to 80s in India. And how it has evolved to fasting BP, A1C, then to the macrovascular screening, and now to time in range. So it's a much more better way extension. So where we can look into the expansion of innovations to the health ecosystem is values. How we see the patients from their angle. we need to put our feet into their shoes. They might be traveling to your clinic maybe 5 kilometers away, 500 meters away, or maybe 500 kilometers from away, and how they would be cared into, what are their concerns and why, what are their pain points, how we can empower themselves to take care of themselves or their system, maybe the whole family. And that could be evidence based. Yes, we have plenty of guidelines, we have plenty of research data available, or we can generate through our systems also in that line, for everyone, for everywhere. That could be possible. So these are the stakeholders, values, and where we can focus is excellence in clinical care. That could be primary prevention. So training them for prevention of food care, for prevention of food ulcers to their food cares, their retinal care, their postures, their exercise postures, their trending to the further way ahead. Secondary prevention when they got detected, and the tertiary prevention for prevention of complications. It could evolve into the medical educations. The doctors at present, when we were trained, we were used to go through the books and look for the research publications. Now we have all available on our phones as well as pads, and newer generation is adapting well. So the education system is also building on the smart platforms, and that's why we can look into further line ahead what could be the possibility around. Even the research work, community care, and how we monitor the whole system. So to reduce inequality of access to the quality care, health ecosystem, diabesity, is it just limited to any age group? Maybe type 1 to pregnancy to older age groups to geriatrics. Is there any specific to any type of diabetes or obesity? Is it any specific to specialized multiple hospitals? Or is it social, cultural differences? Any financial conditions, any countries, or any clinical governance could be part into. And that's where we can drive this whole thing with the collaborations ahead. So interested parties with commonly agreed goals can collaborate on a common objectives to build the health ecosystem for the patient centricity aspect. So it's not only the Dr. Dhruvi or Dr. It is all about ourselves raising the bar for looking into what we could extend the hands ahead for other systems. And that's where we need to build onto. It's not only the registry, it's about real-time coherence and collaborations. And that could be network of specialist researchers, even access to biobanks, even human biological materials, that could be part of. Even we had been collaborating with the University of Chicago for Lentidra, it's islet cell transplant, and that's where we are working. And that could be possible for all of us to collaborate and work into. So it's collaborations of resources as well as infrastructure. Real-time research and aggregations could be the support in further light. It's not aggregation of, I'll say, the drivers. It is about aggregation of our consultants. Could be the part of the system also. It's not Uberization of ourselves. It's also possible. So joint collections and handling of evaluations, that could be part into. And that's where we can build into. And that's for last 5 seconds. You all are invited for 10th and 11th of January for Swasthyakan, and we always build the team around and build onto. Thank you.
Thank you very much, sir, for your insightful session and motivating us.